Bismillahirrahmanirrahim. Quote of the day is, if you are grateful, I will surely increase you in favor. That's the quote from Quran. My name is Dr. Aamna Khalid. I'm PGR Community Medicine, and I will be presenting the topic of rubella under the kind supervision of Professor Dr. Saira Afsar, who is the Dean Institute of Public Health. So the learning objectives are outlined for today's presentation are introduction to rubella, epidemiological determinants, clinical features, phases, complications, diagnosis, prevention, and control measures of rubella, global and national burden, recent advances, and then at the end we will do a practice of MCQs. So rubella is a vaccine preventable viral disease that usually causes mild symptoms but can lead to severe birth defects if contracted during early pregnancy. This is the epidemiological history of rubella. Early detection was before 20th century, and it was often confused with measles and scarlet fever due to the similar presentation of rash and fever, etc. It was first clinically described in 18th century as a mild rash illness, and it was recognized as a separate disease in 1814 by German physicians. That's why it's also called German measles. Then the second milestone was the discovery of the virus. Rubella virus was identified in 1962 by Parkman, Mayer, and Weller. And the third milestone is the major global outbreaks. Um, the major global outbreak was in 1964 to 1965 global pandemic. It was the largest rubella epidemic in history. About 12.5 million people in US alone were affected, and 20,000 plus cases of congenital rubella syndrome, 11,000 fetal deaths, and 2,100 neonatal deaths were there. This pandemic was a major driver for vaccine development afterwards. So the reservoir for rubella virus is humans are the only reservoir, and mode of transmission is respiratory route either via droplet infection like coughing or sneezing or direct contact with nasopharyngeal secretions. Transmission also occurs through transplacental route from mother to fetus. Incubation period is from 14 to 21 days, during which the virus multiplies in the body without any visible symptoms. Period of infectivity, individuals are infectious from 4 days before rash appears to the 4 days after it. Epidemiological determinants includes agent factors, host factors, and environmental factors, and we will go through all of them individually. Agent factors. The causative agent of rubella is the rubella virus. It's a single-stranded positive sense RNA virus of the genus rubivirus, that's from family rogavirus, which is contagious and responsible for the disease spread, including transplacental infection that can cause congenital rubella syndrome. So the host factors includes age. Young children, especially those under 5 years, are more vulnerable to rubella because they may not yet be fully vaccinated and their immune systems are still developing, increasing the risk of infection and transmission. Then is the immunization status. Individuals who are not vaccinated or have not completed their rubella vaccination schedule are at high risk of contracting the infection and contributing to its spread. Environmental factors. The living conditions include overcrowded living environment, poor sanitation, inadequate nutrition, and dry winter season. Healthcare access. Limited access to healthcare services and immunization programs, especially in the rural or underdeveloped areas, increasing the likelihood of outbreaks. Clinical features of rubella majorly include fever, that's low grade, lymphadenopathy, coryza, that's runny nose, arthralgia, malaise, and fatigue, rash. We will discuss the detail of rash in next slides, and mild conjunctivitis. Phases of rubella are four: incubation period, prodromal phase, rash phase, and then the recovery or complication phase. So incubation period is from 14 to 21 days after exposure to the virus, and no symptoms are present during this phase. It's asymptomatic, means no visible signs or symptoms are there. The individual is not yet contagious, but the virus is multiplying in their body. So it's important to note that while the person may not feel ill, they are incubating the virus actually. Then prodromal phase lasts from 1 to 2 days before the rash appears, and the symptoms include low-grade fever, malaise, mild conjunctivitis, coryza, lymphadenopathy. When the lymph nodes involved mostly are post-auricular, occipital, and cervical. Then the rash phase duration is 3 to 4 days, and symptoms are it's the pink maculopapular rash that appears first on the face and then spreads to trunks and limbs. Rash may be accompanied by mild itching, arthralgia, and continued lymphadenopathy. Then comes the fourth, that's recovery or complication phase. Rash now fades in the same order that it appeared, uh, like from face and then downwards the body. And usually, no complications in healthy children, though adults may have some complications. And if complications occur, they can be broadly classified into early and delayed complications. The early complications that occur during or shortly after infection includes arthralgia or arthritis, and especially in adolescent girls and adult women, thrombocytopenic purpura, that is bleeding tendency, encephalitis, though it's rare, and mild hepatitis. Delayed complications are mainly due to congenital infection, and it includes the manifestations of congenital rubella syndrome, heart defects, deafness, cataracts or other eye defects, intellectual disability, and growth retardation. So now I will discuss the infection of rubella in pregnancy. The risk to the mother is that there are usually mild symptoms, including low-grade fever, rash, lymphadenopathy, and arthralgia. But risks to the fetus are severe, including heart defects, for example, patent ductus arteriosus, pulmonary artery stenosis, deafness, cataracts or glaucoma, microcephaly or intellectual disability, growth retardation, hepatosplenomegaly, thrombocytopenia. So in pregnancy, the method of prevention is to give rubella vaccination recommended before pregnancy, not during pregnancy. Screen women of childbearing age for rubella immunity. And the management of pregnant women who contracted a rubella infection is no specific antiviral treatment, but close fetal monitoring through ultrasound, echocardiography, and counseling regarding risk of congenital rubella syndrome. So now we will go through the detail of congenital rubella syndrome. It occurs when a pregnant woman gets rubella infection, especially in the first trimester, and the virus crosses the placenta, causing fetal infection, congenital anomalies, or even fetal death. The critical period is the first trimester, 0 to 12 weeks, but up to 90% chance of severe congenital defects are there. But risk then decreases after 20 weeks, but hearing loss can still occur. So this is the classical triad of congenital rubella syndrome. Number one is the sensory neural deafness. Number two are the congenital heart diseases, especially patent ductus arteriosus and pulmonary artery stenosis. And the third one is congenital cataracts. So eye, heart, and ear are the organs included in classical triad. These are some other symptoms and also some repetition from the previous slides. That ocular manifestations include cataracts, retinopathy, salt and pepper appearance of retina, microphthalmia, and glaucoma. Cardiac anomalies include patent ductus arteriosus, pulmonary artery stenosis, and ventricular septal defects that's less common. Neurological manifestations include microcephaly, developmental delay, intellectual disability, meningoencephalitis. Some other symptoms include a low birth weight, growth retardation, blue Mary muffin rash, hepatosplenomegaly, jaundice, thrombocytopenic purpura, and bone lesions may also be there. So now the connection of rubella and malnutrition will be discussed. It's a bi-directional relationship between rubella and malnutrition. Malnutrition first weakens the immune response, increasing the susceptibility and severity of rubella. Rubella then exacerbates malnutrition by causing reduced nutrient intake, anorexia, and increased nutritional demands. So, reduced antibody response to MMR vaccination and delayed seroconversions will be there. So, it's a vicious cycle that malnutrition leads to weakened immunity, easier rubella infection, and illness occurs. Reduced intake will be there, and worsening malnutrition. These are some of the similar diseases or differential diagnosis, including varicella, scarlet fever, and measles, along with rubella. So now we will briefly differentiate all of them according to the rash type. Rubella has fine pink maculopapular rash. Measles has blotchy red maculopapular rash, and chickenpox has a dewdrop-like rash in the form of pustules or crust. Scarlet fever has diffuse fine sandpaper-like rash. The rash of rubella starts from the face and then spreads onwards within 24 hours and fades quickly. A rash of measles starts at hairline or behind the ears and then spreads to the face and trunk and then the limbs. Chickenpox rash appears in the waves and all stages are present at the same time. It starts from the trunk and then spreads onwards. Scarlet fever rash starts on the neck and trunk and then spreads to the body, but it spares palms and soles. Along with the chickenpox, it also spares that these parts. So, a fever association, rubella has mild or no fever, measles has high fever. Similarly, scarlet has also high fever, and chickenpox has mild to moderate fever. A duration of rash is 3 days in rubella, 4 to 7 days in measles, 5 to 7 days in chickenpox, and 4 to 5 days in scarlet fever. Contagiousness is highest in measles, then followed by chickenpox and rubella and scarlet fever. So, diagnosis of rubella relies on the clinical features and maybe sometimes laboratory test. Clinical features include low-grade fever, maculopapular rash, and lymphadenopathy, and some other symptoms as discussed before. Laboratory test includes rubella IgM and IgG antibodies. IgM antibodies are detectable within a few days of rash onset. Positive IgM means there is recent infection, and the preferred test is ELISA. For rubella IgG antibodies, there should be four-fold rise between the acute and convalescent samples, and that is 2 to 3 weeks apart. That will show the recent infection. Otherwise, a simple high IgG only means that there is past infection or vaccination and it's not the acute disease. Then we can also go for PCR that detects rubella RNA in throat swab, nasopharyngeal swab, or urine, and it's useful in early infection and when IgM is inconclusive. The diagnosis of congenital rubella syndrome also relies on the clinical manifestations as discussed before and the lab criteria, including rubella IgM positive at birth, persistent IgG antibodies beyond 6 months. Maternal IgG should decline normally. And the PCR is positive for rubella RNA in blood, urine, or respiratory secretions. So now we move to the uh, prevention of rubella. The primary prevention includes vaccination and is the most effective method of primary infection prevention, ensuring all children receive the MMR vaccine on schedule and even the vaccination of women of childbearing age. Public awareness should be there, educating communities about vaccination, rubella risk, hygiene, and avoiding exposure. So vaccination, the vaccine administered is the part of MMR, measles, mumps, rubella vaccine, and it's a live attenuated vaccine. The schedule in Pakistan is the two-dose vaccine. The first one is administered subcutaneously at 9 months of age. The dose is 0.5 ml. And similarly, the second dose is administered similarly at 15 months. And it's a part of EPI schedule. Here you can see that during the fifth and sixth visit, that's ninth and 15th month respectively, we give the MR vaccine, measles rubella vaccine. So the efficacy is 93% efficacy is achieved after one dose and 97% is achieved after two doses. So now vaccination of women of reproductive age. Who should be vaccinated? All non-immune women of reproductive age who are IgG negative and they are planning to be pregnant, they should be vaccinated. Postpartum women should also be vaccinated who are found non-immune during antenatal care. The vaccine used is MMR. The dose is only a single dose, and that's enough to develop immunity. When should we administer? We should give before pregnancy. After vaccination, the woman should avoid pregnancy for 1 month. Postpartum vaccination, if a woman is found non-immune during pregnancy, vaccinate immediately after delivery, even if she is breastfeeding. Vaccination in pregnancy. Live rubella vaccine is contraindicated during pregnancy as it's a live attenuated viral vaccine. So, what to do if a non immune pregnant woman is exposed to rubella? Do not vaccinate her. Consider immunoglobulin only. We will go through a detail in the next slide. When exposure is significant, or when the woman, sorry, when the woman refuses termination and when she is early in pregnancy. Even then, immunoglobulin only reduces severity, so it cannot guarantee congenital rubella syndrome prevention. Then the secondary prevention includes early detection of cases through clinical suspicions and a lab test, isolation of the cases of the infected individuals during the infectious period, post-exposure prophylaxis. We should administer rubella-specific immunoglobulins within 6 days of exposure to high-risk individuals to reduce severity and prevent complications. Screening pregnant women for rubella immunity and monitoring non-immune exposed mothers. So the immunoglobulins are rubella specific and they are used for post-exposure prophylaxis in infants under 6 months, pregnant women, or other high-risk groups. Timing is should be given within 72 hours of exposure, but can be considered up to 7 days, but effectiveness usually decreases. Dose is 0.55 ml per kg and it's given intramuscular. These are some of the limitations of immunoglobulin, that it's unreliable in preventing congenital rubella syndrome. It does not protect fetus completely, even if maternal illness is modified. It cannot be used as long-term prevention, and it cannot provide lifelong immunity. So vaccination is needed postpartum. Then is the level of tertiary prevention. It includes management of the patient, rehabilitation, including hearing aids, speech therapy, vision support, and special education. Follow-up care should be there to prevent complications and improve quality of life of patient. So the management is the supportive care and then the isolation and infection control. Supportive care includes rest of the patient, hydration, adequate hydration should be there, fever management, use acetaminophen, that's paracetamol if needed, and aspirin should be avoided in children due to Rett syndrome risk. And symptoms relief should be there, including mild analgesics for joints pain, antihistamines if pruritus like itching is significant. Isolation and infection control. Isolation prevents spread by keeping patient away from the susceptible individuals for 7 days after the rash onset. And public health notification. Rubella is a notifiable disease in most countries, including Pakistan. These are some major outbreak control measures: the case identification through rapid diagnosis of the suspected cases, prompt isolation of the confirmed cases, mass immunization campaigns should be there, contact tracing should be done of the individuals who have been in close contact with the infected person, enhancing surveillance and reporting. This is a global burden of rubella. There is an estimated 1 lakh infants more born with congenital rubella syndrome each year worldwide. Even though a safe and cost-effective vaccine is available, in 2022 there were an estimated 17,865 cases of rubella in 78 countries. As of the data from January 2024 published by WHO, 175 countries out of 194 countries had introduced rubella vaccines, and global coverage was estimated at 69%. Reported rubella cases declined from 97% deaths in figures 6 lakh and around 70,000 cases in 102 countries in 2000, and it declined to 17,000 cases in 78 countries in 2022. Congenital rubella syndrome rates are highest in the WHO African and Southeast Asian regions where vaccination coverage is lowest. These are the WHO East Mediterranean regional data for rubella cases. You can see the countries covered in this graph are Yemen, Pakistan. Pakistan is in blue color, then Sudan, Afghanistan, and some other countries. The data illustration is between 2023 and 2025. It's till June 2025. So more than 88% of confirmed rubella cases in the region were reported from four countries: Afghanistan, including Pakistan, Sudan, and Yemen. This is the distribution of measles and rubella confirmed cases ranging from January 2023 to June 2025. And you can see that Pakistan has confirmed rubella in 2023. The cases were 140. In 2024, the cases were 241. And in the 6 months of 2025, as this data is till June 2025, the cases are 165. So this is some previous data of national burden of measles. This is the map published by Rubella and Measles Initiative. I will tell you about it in the next slide as well. They have they have uploaded this map where outbreaks of rubella um, happen, and this map was uploaded on May 2024, and you can see that Pakistan is among those countries where outbreaks occur. So measles sorry, these are the challenges for these are the WHO's measles and rubella initiative. The goal of WHO has set a target for the global estimation of measles and rubella by 2030 as part of the measles and rubella initiative. This initiative aims to reduce measles death to 95% and eliminate rubella in all regions. So WHO's initiative includes both measles and rubella collectively. Their strategies include vaccination, surveillance, and outbreak response. These are the recent updates. Measles and Rubella partnership between different agencies is there, including Measles and Rubella Initiative, American Red Cross, CDC, UNICEF, United Nations Foundations, WHO, and they have formulated a measles and a rubella strategic framework for the year 2021 to 2030, and they are committed to ensure that no child dies from measles or is born with congenital rubella syndrome. And they claim to help countries to plan, fund, and measure efforts to stop measles and rubella for good. Their strategic priorities are to strengthen primary health care and universal health coverage, and their vision is a world free of measles and rubella. These are their core principles, that their framework is people focused, country owned, partnership based, and data enabled, and the aims are to avert over 50 million deaths by 2030 through access to essential vaccines and help build healthcare systems. This was the nationwide measles rubella vaccination campaign done in November 2025 to protect 35 million children. And these vaccinations campaigns were scheduled in 2025, and you can see in Pakistan, the plan was to target uh, um, uh, to, 2 crore 96 lakh 4,478 children. These are the list of countries published by WHO in which rubella has been eliminated. So in Americas, Europe, Western Pacific, Southeast Asia, Africa, multiple countries have eliminated rubella, and Nepal has recently, in I think in the previous month, uh, claimed that they have eliminated rubella from their country, and that's in 2025. So this is the success story of Nepal, who has eliminated rubella, that they introduced rubella containing vaccine and a high coverage of the vaccine, 4 yearly follow-up campaigns, over 95% coverage that was sufficient to create a herd immunity, and innovative strategies such as annual immunization month, outreach to vaccinate missed children, and the declaration of the fully immunized districts, reflecting strong political and social commitment. Now it's the time for practice of MCQs. First question is, when rubella infection occurs during early pregnancy, serious consequences occur. Congenital rubella syndrome is due to maternal infection with rubella virus. Which of the following statement is true regarding this syndrome? Option A, a description of the 3 days of rash of German measles. Option B, the tetragenic lesions of cataract, deafness, and microcephaly in the fetus. Option C, combination of rash and post-infection encephalitis. Option D, side effects of MMR vaccine. Option E, it affects only the mother and not the fetus.
B.
Yes, option B is the correct one. Question number 2, rubella vaccine is spread via respiratory droplets through the air or close contact. Patients can transmit rubella during asymptomatic infection or from 7 days before the rash appears until 15 days after the onset of the rash. The time frame of greatest risk is from a few days before the rash appears to how many days after the onset of the rash. Option number 1, 5. B is 7. Option C, 9. Option D, 11. Option E, 13.
B.
Is option B is the correct one. A 28-year-old woman who is at 11 weeks gestation comes to the clinic for a physical examination and to receive appropriate vaccinations before beginning a job at a daycare center. The patient's medical and immunization records are unavailable. Which of the following is the most appropriate next step about administering this patient the measles, mumps, and rubella vaccine? Option A, administer the vaccine at 20 weeks gestation. Option B, administer the vaccine at 32 weeks gestation. Option C, administer the vaccine at this visit. Option D, administer the vaccine after the patient gives birth. Option E, recommend against receiving the vaccine.
D.
Yes, option D is the correct answer. During pregnancy, the vaccine is contraindicated. Question number 4. In a recently conducted retrospective cross-sectional study carried out at a fertility clinic in Islamabad, 730 pregnant females who visited for antenatal checkups were analyzed. Identify the most suitable method to find congenital rubella syndrome. Option A, polymerase chain reaction, that's PCR. Option B, complete blood count, that's CBC. Option C, serum bilirubin test. Option D, urine protein analysis. Option E, chest X-ray.
A.
Yes, option A is the correct one. PCR detects RNA of the virus. Question number 5 is between 25 to 50% of those who have rubella do not realize that they have it. This means that a person can meet rubella and become infected without realizing it. All the following statements are true about congenital rubella, except which one? Option A, it is diagnosed when the infant has IgM antibodies at birth. It is diagnosed when IgG antibodies persist for more than 6 months. Option C, most common congenital defects are deafness, cardiac malformations, and cataracts. Option D, infection after 16 weeks of gestation results in major congenital defects. Option E, the rubella virus can cross the placenta and cause fetal infection.
D.
Option D is the correct one. Question number 6. A male baby is born at 39 weeks gestation with a petechial rash, low birth weight, hepatosplenomegaly, and bilateral cataracts. This is thought to be due to an infection acquired while the baby was still in utero. Select the condition which is most likely to cause this clinical manifestation. Option A, cytomegalovirus infection. Option B, group B, streptococcus. Option C, rubella virus. Option D, toxoplasma gondii. Option E, treponema pallidum.
Charlie.
Yes, rubella virus. Question number 7 is 2,000 pregnant women attending the antenatal clinic of the Aga Khan University Hospital were tested. Susceptibility to infection decreased with age and parity, and greater attention should be paid to immunization of women of childbearing age. How does rubella cause fetal abnormalities? Option A, by crossing the placenta early in pregnancy and infecting the fetus. Option B, by only infecting the placenta. Option C, by inducing cytokines and chemokines in the mother. Option D, by raising the temperature of the mother and inducing an abnormal immune reaction in the fetus. Option E, by causing direct damage to the mother's immune system.
A. A.
Yes,
Alpha.
option A, that's transplacental. Question number 8 is rubella is a vaccine preventable disease. Multiple vaccination programs have led to a dramatic fall in the number of the cases, and it has been declared eliminated from many regions of the world. Which one of the following is a contraindication for the rubella vaccine? Option A, allergy to eggs, pregnancy, receiving immunoglobulin in the past 3 months, a documented history of the disease, personal history of febrile convulsion.
Beta.
Yes, beta. Question number 9. Most people who get rubella usually have a mild illness with symptoms that can include a low-grade fever, sore throat, and a rash that starts on the face and spreads to the rest of the body. The age group most prone to rubella is children 3 to 10 years, adolescent girls, pregnant females, women of childbearing age, and elderly population. Children are most vulnerable to rubella. Question number 10, the last one. The rubella virus vaccine is used to help prevent this disease in adults and children who are at least 12 months old. All statements about the rubella vaccine are true except option A is the vaccine prevents reinfection, thereby limiting the spread of the virulent virus. Option B, the immunogen in the vaccine kills the rubella virus. The vaccine induces antibodies that prevent the dissemination of the virus by neutralizing it during the viremic stage. Option D, the incidence of childhood rubella and congenital rubella syndrome has decreased significantly since the advent of the vaccine. The vaccine is recommended for all children, adolescents, and non-pregnant adults who have not previously been vaccinated or had rubella. Option B is the correct one. This is the answer key to all of the questions. This is the YouTube channel of Institute of Public Health Lahore where the presentation will be uploaded. Thank you.
Thank you very much, Amna. It is a good presentation. The most important slide that you have shown is that there are so many countries that have been able to eliminate rubella. As we are moving ahead with measles rubella campaign, this point has to be stressed again and again. Even the countries who have GDP even less than Pakistan, they are able to eliminate rubella from their country. May I ask you what is the difference between control, elimination, and eradication? Amna?
Eradication is that we reach the zero cases. There is no case anywhere. Elimination is, I think, to remove the infection or the transmission from some specific region, and control
And
is to
control?
stop the spread of the infection.
Right. So the control is actually decreasing the transmission of the agent to the susceptible host in a specific area in a specific time. So usually we are talking about the control of outbreaks, control of infectious diseases, and control of rubella disease, measles, etc. In Pakistan, we are not able to eliminate even measles, polio, rubella. However, there are many countries who are able to eliminate it. Eradication is that when the disease agent is removed from the areas of the whole world, and the only example where the eradication has been done is smallpox, because the smallpox is no more present in any area of the world. However, the elimination There are many countries who are able to eliminate measles, like USA, and they are able to eliminate polio, like India, Sri Lanka, Nepal, Nigeria.